Yo, what up? This is Josh Rubin from East West Healing and Performance, and today I want to talk about hip pain, another school of thought. Now, of course, I'm not denying the fact that someone might have hip pain or pelvic pain for many reasons. Of course, it could be issues coming from the foot, the bones, the fascia, the ligaments, structures, trauma, surgery, scar tissue. Same thing coming from the knee, ligaments, capsule. It could be arterial, etc. Or it could be coming from the above. It could be coming from the cranium, the sutures, the different fascial connections, cervical spine, thoracic ring, organs, etc. I'm not denying that. I'm kind of focusing on one thing in this, just to obviously summarize it, because we got about 10 minutes on YouTube here. I'm not denying that people could have capsular issues in their hip. It could be ligamentous, the ischiofemoral and iliofemoral and pubofemoral ligaments could be wound up, as simple as that. Could be more structural, like arthritis or something like that. Could be a leg length discrepancy, etc., etc. But I'm focusing on one area because it's something you never really hear. It's something that's never really talked about. Now, of course, it's 10 minutes. I'm going over some key points here, just to hopefully so you can understand some of the connections in the body. Now, from this, what do? Of course, do your own research. It's a 10-minute YouTube. There's only so much I can cover. At the same time, I recommend someone seeing a skilled, either visceral massage therapist, if you can find one through the Burrell Institute, or a skilled osteopathic manual therapist. Some of that's manual therapy. Most of them are typically trained outside the US and Canada, France, Europe, UK, things like that. And they're hard to find in the US. I know according to my school, we probably have 15 in the US that have actually graduated from the US. So they're far and few between. But I think these videos are important because it's important to bring awareness to structural issues, because everyone always thinks about, if I have pain, it's a muscle. And that's, that's a somatic to somatic issue, muscle to muscle. And that's how everyone thinks. And unfortunately, this is obnoxious, I think that's a really limited way of looking at the body. And it really doesn't show your understanding of how the body works, because you have sensory and motor input to different parts of the body, to different organs, etc. So the somatic system has motor and sensory output, afferent, efferent. The visceral system, according to Pottinger in Symptoms of Visceral Disease, he states that the visceral system, organ system, actually shares sensory input from the somatic system, because it doesn't have its own sensory system. So the question is, when you have a pain, is it somatic, meaning muscle causing muscle pain? Is it somatic visceral? Is the pain a muscle issue causing a visceral problem? Or is it visceral, an organ causing an organ issue? Or is it visceral somatic, an organ causing a somatic or muscle, a ligament, a tissue issue? We have to think about all four scenarios, because if we don't, we're really not looking at the body as a system of systems. We're ignoring so much. Now, I'm not here to bash anyone. I'm just saying, if you study the muscular system, you've got to look at other systems in the body, because there's more to the body than just muscles. That's just a suit that we wear. But we have other suits, like the lymphatic suit, the circulatory suit. You have the fascial suit, the ligamentous suit. You have the osseous suit. You have the visceral suit. You have the fluid suit, the emotional suit, etc., etc. So we're ignoring all these other bodies that can cause muscular pain. Now, if we talk about the pelvis and hip pain, I'm kind of correlating this with menopause. I have a lot of my notes, so if I look down, I'm referring to my notes. Now, of course, women go through menopause. Of course, it's older age these days. But nowadays, you see many women actually going through menopause in their 20s and 30s. I've worked with them. Their menstrual period actually ceases for over a year, or for greater than 3 to 6 months. They're actually going through menopause. At the same time, I worked with women in their 30s that actually don't ovulate. So we have to think about this. What is going on hormonally? What is causing that? What can we do to help these people? But what's going on at a structural level as well that could be contributing to maybe some of the pain they're actually complaining of? Now I'm going to focus on a little bit localized, somewhat regional, and somewhat global. So during menopause, because of hormonal changes, now it's been shown by Dr. John Lee that progesterone levels drop to the bucket. Estrogen levels actually drop about 40%. That's it. Now, because of this severe drop in one and slight drop in the other, now, of course, you're still producing estrogen in your fat cells as well as your adrenal glands. That's why it doesn't drop, to the bucket, but progesterone does. And it also drops because of stressors in our lives as well. It's not just because you're getting older. There's no such thing. Aging is a stress, and you can easily manage that with the right nutrition and living the right lifestyle principles to manage the stressors that are going on. So typically what happens is the uterus actually shrinks. Now when the uterus shrinks, of course, the vaginal epithelium gets thinner. You lose a lot of the protective fluids. You get hot flashes. You get night sweats. You have trouble sleeping. You got mood issues. You got joint pain, etc. That's typically what's going on. And typically you see issues within the endocrine system. The genital system changes within these systems. The cardiovascular system, you typically see increase in lipids and things like that, blood lipids, as well as the bony system. You'll see demineralization of bone. That's why women, during hormonal changes, whatever that may be, actually end up with osteopenia or osteoporosis, which is a progression. So if the uterus shrinks, now I'm going to take a little tangent here. If you look at the pelvis in itself, you have a triangle. You have the sacrum right here, going out to the pubic bones. So you have the sacrum. Okay, so the sacrum's right here, going out to the pubic bones, and that's more of a structural, musculoskeletal triangle. And then you have the coxfemoral joints. I'm going backwards to the coccyx. To the coccyx, which is another triangle, which is more of a fascial, myofascial triangle. And in between that, you have the rectum, the bladder, the vagina, the prostate, etc. But these structures within the pelvis, especially the uterus and the vagina, now we're focusing mostly on females, the prostate plays a role in this, which I'll talk about a little bit, is they're actually suspended. And the stability of the bridge is dependent on whether these structures are going to be tightened or actually loosened. You get a visceraptosis, things like that. So your suspension bridge is only strengthened through the tensioning of certain wires, per se, kind of like a bridge. So the important structures are the coxfemoral joints, the coccyx, the pubic symphysis, both of them, as well as the sacrum. Weakening of any part of the structure can disturb the balance and the equilibrium of all the contents within the pelvic structures, which can affect, of course, equilibrium, strength, as well as function. Now, the vagina and bladder are suspended from this bony pelvis from ligaments. The pubo-uteral ligament, the utero-sacral ligament, which I'll talk about, and the Arcus tendinus fascia, and the perineal fascia, which I'll talk about. So the suspension of these organs is dependent on those structures as well as the ligaments and fascial connections coming from those structures. And we could say that the structures can influence the ligaments and the viscera can affect the ligaments and the structures, leading to structural issues. Or the structure can lead to ligamentous and visceral issues, causing a lot of symptoms that you're having. Now, if we focus on the uterus, we're focusing on one ligament. There's much more to it than this. It's a big ligament that comes off the uterus, kind of looks like a big butterfly. And it attaches to your innominate bones. An innominate bone is 3 bones: the ischium, iliac, and pubis. I think it attaches pretty much to the inside of the iliac fossa. Correct me if I'm wrong, but I think. So it's the broad ligament. Now, if the uterus shrinks during menopause, whatever age that may be, you see tensioning in the broad ligament. Now, the broad ligament not only is going to pull on the iliac fossa, which can cause many different disturbances. Maybe it pulls it posterior and inflare. So it creates a posterior rotation and an inflare and an adduction of the short arm on the sacrum. So it can do 3 different things, which can create a lot of tension within the pelvic bowl, lead to that kind of flabby butt, tension or pain within the abdominal area, constipation, etc. Can lead to visceraptosis. But at the same time, it actually has fascial connections or continuous with the renal fascia, which is in the low back, per se, we could say, which is continuous with the internal external oblique and the 12th rib. It's continuous with the iliac muscle, which attaches to the femur itself, the trochanter. And it's continuous with the transversalis fascia in the abdomen. Now, this is important because if we have changes within the structure, which is the uterus, this is a very important structure within the central train of the body. The central chain of the body is the central axis of the body that everything kind of, regulates around. And the central axis actually starts at the vertex, goes to the third ventricle, the SBS, the esophagus, trachea, and thyroid pouch, the pericardium, the phrenic center, head of the pancreas, the root of the mesentery, the isthmus of the uterus, the retropastatic fascia, and the perineum. So you can see how an issue with the uterus can affect all these structures above and below, leading to other regional and global issues. Now, my point in this is to show that people that typically go through menopause and have shrinking of the uterus, because of the tensioning of the broad ligament, and because of its continuous nature with the iliacus and the renal fascia, a lot of these people end up with back pain and hip pain that comes about when they go through menopause. Everyone mobilizes the hip, stretches the iliacus, stretches the psoas, does McKenzie, does all these different things, but in all reality, it's the shrinking of the uterus that takes the uterus maybe off its axis, that creates tensioning in those issues, that's leading to a root and branch effect in the iliac and the hips, causing hip pain. So the real thing that we have to focus on is how can we actually work on the uterus, as well as some of the structures of the central chain, to regulate hip pain. Not ignore the hip pain, but maybe the hip pain is actually a result of the shrinking of the uterus. Another important thing to think about is the uterus is actually attached through another ligament, through the Utero-sacral ligament, to S2 of the sacrum, which can lead to, because of the shrinkage, a lot of times what you'll see is an axis lesion of the sacrum, an AP axis. It'll actually go to one side, or it'll actually, through PRM, rotate back and forth instead of nutation and counternutation, or flexion extension. And this ends up with a lot of women ending up complaining of iliosacral pain or sacroiliac pain, pain in the groin, pain in the L5-S1 area, or pain on one side, kind of near where the sacrum meets the ilium or the ilium meets the sacrum. So you can see how the uterus can affect the sacrum, the ilium, lead to sacral pain, low back pain, through their connections and structural connections, as well as lead to hip pain. We have to think about these things because when we're working with people, we can't just go, oh, you have hip pain, let me work your hip. I know the muscles, I know the ligaments, I know the capsule, bam, I'm going to work your hip. 99% of the time, you're going to work the hip, they might feel better, it's going to come back because you've ignored the real issue. Whether it's from above or below, there's many, many scenarios, but the bottom line is, what if it is because hormonally what they're going through, and you have shrinkage of the uterus, affecting the broad ligament, affecting the pelvis and the hips, and the renal fascia, leading to back and hip pain, as well as affecting the utero-sacral ligament, creating torsion, we can say, or more of an AP axis kind of rotation issue in the sacrum, leading to low back and sacroiliac pain. So we have to think about these visceral-somatic connections and not just somatic. So hopefully you've enjoyed this YouTube. I thought it was going to be a quick one, but once again I'm wrong. I'm out of here.